Right, so I'm Jodie. I'm the specialist bariatric nurse over at Salford, and I work with a fabulous team. Oh, hang on. 1 second. It's not moving forward. Oh, okay. So we have a lovely group of surgeons. As you can see, there are 6 key surgeons and Mr. Ahmed, who is a very talented surgeon who assists most of our professors. We also have a team of medics that you will meet, and they look more into your personal history as you go through the journey with us. We have your support, which is me, our dietitians. We also have a psychologist on board, and Jackie Evans, who's our bariatric coordinator. So for any of you that used to come to the evening session, she would be the one signing away your forms to say that you attended. And just if any of you are concerned, obviously while we're doing these Zoom meetings, you don't need to worry about those forms being signed at the moment. And then once you're at the stage where you can proceed to surgery, it's your surgeon's secretary who's really key. So when you meet your surgeon, you'll receive a letter with a summary of everything that we've gone through. And in that top corner, it's key to note that's your secretary with her number. And then if you've got any issues with where you're up to and so on, they can help answer those questions for giving you a date for surgery. And our service manager is Louise Farnworth. Okay, so your journey, all of you at the moment are going to be part of a weight management program. Once you've completed that program, they refer you on to us. At that point, you'll be in a sort of a queue. So normally within 3 months, we will contact you and start you on your journey to surgery. So initially this is going to be done by telephone, and that will be with myself and the dietitian colleague. And then you'll have an appointment with your medic and your surgeon. And obviously going forward, you'll definitely meet your surgeon before the day of surgery. What happens after that? We discuss you in something called a multidisciplinary meeting. So each of you have a very individual journey. You may have other health conditions that we need to look at. So don't worry if you think, oh, well, I had a heart attack some years back, or I've got this condition, maybe that means I can't have surgery. And that often isn't the case, but sometimes we might want more details to make sure that you're safe to proceed. At that point, we would list you for surgery, and your surgeon, you would know who your surgeon is. Sometimes we like to do a sleep study. So some of you may be on something called CPAP already, and some of you may not know what I'm talking about, and that's fine. We have a sleep service at Salford. It's quite common sometimes with obesity, or if you're someone who snores at night or has a large neck circumference, that you have something called sleep apnea. And this is where you have an absence of breath during the night, which prompts your body to go, wake up, you're not breathing. And it means that when you wake up in the morning, it's as if you never slept. You're always tired. So we test for this because our anaesthetist, who looks after your airway during your surgery, will want to know if you've got that condition. And sometimes by identifying that condition and having a CPAP machine to help you sleep means that you will be able to proceed. Means that your quality of life could actually be improved before surgery. So it's a worthwhile test to have. Some of the services you're with already have a psychologist, and some don't. At the time of MDT, it's most likely that all of you will need a psychology assessment. This isn't anything to be worried about. You don't pass or fail psychology. It's a really useful tool. So it's looking at where you've been, where you are now, and where you're going, and giving you a bit of a mental toolkit on how to look after yourself psychologically as well, because bariatric surgery is absolutely body and mind. So we're really keen on our psychology involvement in our service. The surgeon secretary will send you the letter, and as I said before, their contact details will be there, and they track you to your surgery. When you're ready for surgery, the surgeon secretary will arrange for you to come in and have a preoperative assessment. That's something that everybody has to have, and it's the final thing to make sure that you're fit for surgery. You'll be given an admission letter, told where to come to, the liver reduction diet that you need to do. And don't worry if you don't know what a liver reduction diet is. We make sure that you're very prepared for this and all the education you have once you're with our team. Having followed all the fasting instructions and bringing in all your medication on the day of surgery, you'll be consented and taken to theatre. And there is one of our theatres, and the two surgeons you can see there concentrating very hard, as they should. That's Professor Senapati and Mr. Ahmed. So the day of surgery, when they take you to theatre, all surgery is done laparoscopically. It means keyhole surgery. So we make 5 incisions under a general anaesthetic to your abdomen. We blow it up with a carbon dioxide gas, and that's just so we can get our equipment through easily without bumping into things. We do your surgery, and the surgeries we offer are the sleeve gastrectomy, the single anastomosis bypass, and the Roux-en-Y bypass. Now, if you're thinking, oh, what are all these things? Don't worry. Again, once you're in our team, you'll be very aware of what those surgeries are, and we'll give you guidance on which one we think would suit you best, but you already might have a good idea of the surgery that you quite like. So once we've done your surgery, we put a blue dye down. Now the blue dye goes down your esophagus. You're fast asleep, so you won't know about it, but you might wake up with a little blue dribble, so don't worry. And when you go for your first wee and it's green, don't panic, that's the blue dye test, okay? And the reason we do it is because the surgeons like to look at where they've done their surgical joins, and at the time of closing you up, they know that that is as sound as it should be, that it's all nicely sealed and nothing's leaking through there. So they'll do your surgery for you, then we release the gas. Now, when I've watched surgeries, the little holes, the gas just kind of goes through the holes. No one's going to leap on you to get rid of that gas, okay? So sometimes in the first few days after surgery, you might have a niggly pain lower down in your abdomen. You just need to walk around and your system will work that out. But it can cause a niggly pain, so that's just something to be aware of. The cuts on the outside are usually sutured or glued. And then we take you round to our recovery and make sure that you're not in any undue pain. And I say undue pain, bariatric surgery is a major surgery. It's very likely that you'll know a bean. You might feel a bit bruised, you might feel quite sore. If you move quickly, you might get a sort of feeling, but we absolutely need you to do that full range of movement. And in recovery, if you're not able to get yourself up the bed or sit up or transfer out, we'll give you some good painkillers so that you can achieve the things you need to do. And then from recovery, they'll take you to the ward. But some of the things you need to know, the risk associated with laparoscopic surgery, and not just bariatric surgery, this is the case for many surgeries. There can be complications with a general anaesthetic. Now, you will go to pre-op and you will be given information on this. And I've Googled complications of general anaesthetic, and it's very accurate. So I'll let you do that yourselves, because otherwise you're going to have a lot of information. Chest infections, so you need to be pain-free enough that you can do a nice deep breath and a cough or a huff, just clearing those airways just to make sure that you don't brew a chest infection, because you wouldn't notice it in hospital. The idea would be that you come in on the day of surgery, and in most cases you go home the following afternoon, evening. Wound infections, again, these wouldn't develop in the hospital, but if you did develop one, it would be your laparoscopic wounds. You'd look down, they might be red, they might be hot, there might be something yucky coming out of it. If you're coughing up something green, then you need to get straight onto your GP. And with bariatric patients, our GPs don't know everything about everyone, so you do need to tell them that you're in the liquid phase of the diet, and they will prescribe you liquid antibiotics, ideally sugar-free. The other things we look at, trying to prevent you getting any clots in your legs or lungs, and we're very good at this. As soon as you step into hospital, we whip on anti-embolism stockings. They are not one size fits all, and we have many sizes, but if they don't fit right and they cut in, then it's worth not wearing them. And instead we give you these little like leg massages that you wear overnight. So if you wake up in the night thinking, oh, who's grabbed my leg? No one's grabbed your leg. It's just that little leg massage. You're just helping maintain that you don't get any clots. The other thing you would have is little blood thinning injections as well, to take home. So just make sure that when the nurse comes to you and goes, oh, here, have a go at doing this injection, that you can do it. And if you can't do it, that there's somebody at home that's quite happy to stab you each day. Other complications with surgery, the most serious is something we call an anastomic leak. I don't at all expect you to remember this. You're going to have all this information again nearer the time of your surgery, but there are things to consider when you make an informed choice around surgery. So yeah, an anastomate leak, less than 1% of patients would have this, and it's where the surgery inside has broken down, and it means that you have a hole in your gastric tract, and this is not good news. You would need to be looked after in a hospital setting. You'd probably be nil by mouth. You might be able to swill your mouth. This may include ulcers. So something that you do need to be aware of, the risk of ulcers is increased dramatically, and other complications such as stricture and that can lead to malnutrition in smokers. So part of your preparation for surgery, if you are a smoker, is to be a non-smoker before you're referred to us. And so absolutely raise that with your team, or go to your local pharmacy, or look for some cessation, because by the end of this, you're going to be really, really healthy. But in all seriousness, it's very important to be a non-smoker for surgery. Sometimes there can be bleeds, hernias, or less than 3% of patients. And again, all these complications I'll go through with you nearer the time. There is a risk to life with bariatric surgery. Nationally, the mortality rate is 0.08%, collected between 2014 and 2018. The benefits, hooray! So I'm sure all of you have your very personal reasons for being on this journey. But there are lots of things that us as medics and physicians and healthcare professionals get very excited about with bariatric surgery. So if you've got a recent diagnosis of type 2 diabetes or sleep apnea, very quickly with bariatric surgery, those things can go into remission, which means long term you're going to be healthier and at less risk of other diseases. People who've had high blood pressure, they don't need to take that medication anymore. And lots of things to sort of, you're in a fork in the road, and hopefully you'll go down the one where you can dodge things such as heart disease, stroke, and now obesity is the lead cause of cancer as well. So we just hope overall you'll be a healthier person. But the privileged position I'm in when I meet you all around the 4-month stage after surgery, when you've gone through quite a rapid weight loss, is people genuinely feel like they can do more. And it's not because they didn't do anything before, but they just want to do more, and you can't really underplay that. So if you can see this screen, just have a little read through. But as I say, I'm sure you've all got your reasons that you want to have this surgery. Oh, this is the fun bit. So if you've come to the meetings before, we sometimes do patient presentations where they come up and they're the brave souls, and they tell us about their journey, and they tell us, they let us have a look at how they've got on and the weight difference. So some of them have been very kind and said that I can share some before and after pictures with you. And so we'll just go through those now. There we go. And this chap's lovely because he's very young really for having bariatric surgery, but he's now just qualified as an occupational therapist, and he really feels like having lost that weight, it's given him opportunities that he felt more nervous about pursuing before. Okay then, so when you've had your surgery, some things may well change. So when lots of you may be on other medications and be a bit nervous about what you're meant to be doing with those, you are going to meet a medic, and they will go through all your history, and they'll look at all your medications. Straight after surgery, you'll be assessed for what's essential for you to take. So you might be quite surprised by how little you take in those first 3 weeks after surgery. So we review that and we look at alternative routes. So at first, you might be given some medicines that don't particularly taste nice, or they might be crushed, or they might be a syrup. If they're smaller than a 5p piece and they're absolutely essential, you can take those as well. But we look for other routes. And I do think with pain management particularly, you should definitely consider doing this before surgery once you've got your date, so that you've already got yourself into a better place with that before surgery. So that's something else to think about. So all tablets can be taken from 3 weeks. So even though in that initial 3 weeks we're like, oh, don't have anything, suddenly you've got lots of supplements that we give you as well, because after bariatric surgery, you're never going to get everything you need from food alone. So we do need supplements lifelong. So if you know you're not very good at taking tablets, then that's something you need to think about as well. The key is to spread them out. When you have your surgery, your stomach capacity is much, much smaller. 30 to 60 mils, the size of a small boiled egg. So if you fill yourself up in the morning with tablets, it means you won't be able to have breakfast. So you have to get used to spreading them out throughout the day. Some may never restart, as we said before, and some you should never take because of the surgery you've had. So anything that your gastric system wouldn't normally like, for example, naproxen, ibuprofen, we call them non-steroidals. They're anti-inflammatories that aggravate the stomach lining and can cause ulcers. They're things that you should never have after surgery. And absorbing medications, it can change. So for example, if you're a lady and you've had a bypass and you rely on a contraceptive pill, you should not rely on it after surgery because it won't absorb in the same way and we can't guarantee the efficacy. Maybe you're on some antipsychotics, maybe you're on some other medications that you rely on. So with the medic, you'll look at those, because after surgery with weight loss, everything needs a tweak. Sometimes you might need more of something to get the same effect, and sometimes you'll need much less, or if at all. Okay, so follow-up is really good with our service, and we really have found statistically people do better with their weight loss long term if they attend the follow-up sessions. So at first you just can't get rid of me. I'll be phoning you all the time, but don't feel sore if you think, oh, I haven't had a phone call. You're going to have my number from the time that we take you on as our patients. Okay, and the dietitian does the same. You'll have 2-year follow-up with the surgical and dietetic team. But then yearly, the medic you meet initially will follow you up every year around the anniversary of your surgery for life. And that's something that nowhere else on the planet offers. And it's a really good tool for you and your GP going forward. You can access our bariatric support groups. They're ever changing at the moment, but there's access for additional support. And we also have a buddy scheme. So if you're a bit nervous about surgery, you can contact me and I can buddy you up with someone beforehand or after surgery as you're going through the change. It can be quite overwhelming for some. You've been gearing up for it for so long and then it happens. Sometimes it's nice to have someone who actually understands what it's like, who's a little bit further along than you. So we can buddy you up as well if you'd like that. What can you do now? So I've stop smoking, I've touched on that already. Start dietary habits for the lifetime. So really, they're small changes, but they will make such a difference after your surgery. So it's trying to have those 3 regular meals. Understanding what protein is. Protein is your absolute key target of every meal after surgery. So whatever you eat, you need to know what your protein is, eat that first, and if you've got room, have everything else. Drink around 1.5 litres a day. So learn now to sip, because after surgery, if you're thirsty, you won't just be able to net back a pint of water. You won't have that ability. If you tried to do that, it would just regurgitate up. It's too much too quickly. So it's learning to sip throughout the day. So wherever you go, you should go with your mobile phone, your house keys and a bottle of water, and just learn to try and sip throughout so you're not getting to the thirsty stage. And also you wouldn't be able to have things like fizzy drinks after surgery. So if fizzy drinks have always been a bit of a crux, it's a good thing to identify now, rather than learning the hard way afterwards. Some people who really, I know there's Diet Coke seems to be a big one that people really like, and where people have tried to have that afterwards, there is the danger that even if you can tolerate it, that gas bubbles and anything like that could stretch potentially your surgery. So it's just getting into good habits beforehand. Right then, that's the end of my presentation. So if any of you've got any questions,